It's my pleasure now to introduce the second speaker. The topic is breast elastography, and it's my pleasure to introduce Professor Viorela Enachescu from the University of Medicine and Pharmacy in Craiova, Romania. So if we have Viorela, please, Viorela, you're online.
Thank you very much, Toyu. I will speak about breast application of the new guidelines and recommendations of the clinical elastography non-liver applications. Thank you anyway, Professor Cantisani, which made much easier my work. That update of the 2013 EFSUMB guidelines was established last year in February and will be in press soon, I hope till June of this year. The first recommendation is about training. The operator should obtain adequate knowledge and information about ultrasonography and elastographic methods, and in examination within the medical legal framework of the country, because EFSUMB have 3 levels of competence and applications of elastography. The first level is operator that have best competence level to evaluate lesions in various organs by B mode and Doppler. They also need to have knowledge about the patient, about the clinical history, hematological and biochemical parameters, and comparative imaging findings. After that, they have to follow international guidelines and obtain adequate knowledge and information. So, as terminology, strain elastography is also mentioned in the last guidelines, but as new terms, acoustic radiation force impulse as RFI is a new one, imaging and different forms of shear wave elastography, so transient elastography, point shear of elastography, and multidimensional shear wave elastography, 2D and 3D shear wave elastography. Ultrasound elastography methods employ ultrasound on internal tissue, shear deformation resulting from a force, from an applied force, but the type of force is very important. So the second recommendation about safety is to comply with safety, the ALARA, as low as reasonably achievable principle, then should be applied when using ultrasound elastography, because there are some mechanical side effects, for example, on sensitive tissues, eye or fetus or bone, which are the simulations have revealed a possible temperature risk rise of about 5 degrees. The third recommendations is caution is recommended for shear wave elastography using long pulse sequences, particularly when exposing sensitive tissues. The methodology of elastography consists in 3 points of actions: mechanical constraint induced to tissue, external or internal constraint, measurements of tissue deplacements, and estimation of tissue stiffness. So we will talk about qualitative strain or quantitative estimation elastography. SonoElastography as clinical applications have to improve differentiation between benign and malignant disease. For example, on this very well-known score of Tsukuba or Ueno, we could see the 5 degree of elastograms concerning the stiffness of the lesions from score 1 to score 5, and from liquid lesions we are the last score, which is 3 layers colored in blue, green and red, and about some images to exemplify. So we have in the first one benign lesion, which is colored in green. The second one is benign lesion 2-3 degree, which is colored in blue and green, and the last 2 ones are the 4 and the 5 degree, which are colored only in blue, and the last one for the 5 degree is bigger than the B mode image. Strain elastography display tissue rate and strain rate, and present the special gradient of displacement or velocity. So in this way is a quasi-static elastography, because the force which is applied varies very slowly. An optimal elastogram include 3 mandatory structures. For example, the glandular tissue, the surrounding fat, and of course the lesion. Tsukuba score in this picture is in e-Sie-Touch elastography. The red color means 4 and 5 degree of the cancers. The Tsukuba score, the best cutoff point for discrimination benign from suspicion malignant masses is between score 3 and 4, because we have the color green or blue, or which is dominant, and strain elastography, in addition to B mode ultrasound, increases the specificity of the examination up to 97% after SADC, and helps to avoid unnecessary biopsies. Anechoic lesions with liquid content show a typical degree layer that I already showed. Strain ratio measurement is the quantitative aspect and parameter of the elastography. So you have on the picture. Sorry, I cannot show because I have no. So you could see on the picture the A, which mark the fat and the hypogenic structure, and B, which mark the lesion, and the ratio between strain A and strain B is the fat to lesion ratio. So to define the index, the ratio for the lesion, and reporting to the fat. For example, a fibroadenoma which have the fat to lesion ratio 1.2, and an invasive ductal carcinoma which had fat to lesion ratio 8.9. Yes. Strain elastography as clinical applications is very present in many studies. For example, in 99 non-palpable benign and malignant breast masses, an optimal cutoff of the strain ratio is 2.24. The higher the strain ratio, the higher the risk of malignancy. Meta-analysis analyzed the accuracy of strain ratio in 9 studies, and the sensibility and the specificity was proven very high. And ratio elastography on B mode lesion increases with the increasing tumor grading, low-grade tumors having a ratio close to 1. For example, a real-time elastography by compression presents some sequences of the same lesion, which appear very lobulated with very irregular borders and very hypoechoic on the B mode image, and on elastography the same lesion is quite blue, a 4-degree elastogram for a cancer. Another way to color the image is the mode e-Sie-Touch elastography, which color in red the much stiffer tissues, the stiffest tissues. For example, a fibroadenoma is in the left side of the pictures, degree 2 and 3, which are colored in red and green, and in the right side you have a 2D aspect showing a possible benign aspect, but which is in elastography showed as a malignant one. And the last one is a malignant aspect for 5 degree, which is larger than the B mode image. SHEARWAVE elastography display SHEARWAVE speed and measure the arrival different time of a SHEARWAVE of different locations. The measure units are either meter on second, but maybe also reported in kilopascal, depending on the system used. As far as the optimal image should include the lesion, the fat, and the glandular tissue. Malignant tumors are more heterogeneous and stiffer and inhomogeneous, reporting to benign tumors. Often the stiffness seems to be most marked at the periphery of the mass and may demonstrate such high values that the system is unable to record a measurement. For example, in this image, you could also you could see the SHEARWAVE elastogram, which need to cover the lesion, the fatty tissue, and the glandular tissue. SHEARWAVE elastography in a multi-center study. The additional of SHEARWAVE elastography resulted in some BRADS3 lesions appearing stiffer and potentially allowed for an upgrade to 4A mass, mandating a biopsy. The overall sensibility and specificity would have increased to a very high level versus the same parameters for B mode ultrasound alone. Increasing stiffness has also been shown to correlate with increasing tumor grading. There are many studies which are showing this way. Another SHEARWAVE elastogram, 3D elastogram SHEARWAVE, which are demonstrating a malignant lesion. In cysts with pure liquid, no signals are obtained, and the SHEARWAVE elastogram show a lesion as a black image. However, in cysts with a higher viscosity, SHEARWAVE signals may be obtained depicting the cyst and having a low stiffness. On axillary lymph nodes, the sensibility is 82% and specificity 69% using SHEARWAVE elastography to distinguish between benign and malignant lymph nodes using a cutoff of 1.44 and using strain elastography, the sensibility and the specificity was lower for the sensibility and higher for the specificity for the diagnostic of malignancy. Another study compared elastography and B mode. No significant improvement was shown when elastography was added to a benign mode ultrasound. As prognosis, the histological and pathological analysis based on cancer and also the immunohistological analysis showed a significant correlation between stiffness of a breast cancer and prognostic factors. When we have triple negative carcinomas, which are often evaluated with BRAF3 in B mode ultrasound, is quite difficult to assess in clinical practice, and SHEARWAVE elastography is reported to show increased stiffness in these cases and can lead to the correct assessment. About neoadjuvant therapy, the efficacy of the neoadjuvant therapy in a study with a small sample size of only 15 patients, the possibility of predicting a response to neoadjuvant chemotherapy with the strain elastography was reported. However, large studies are not available again. A significant correlation for the response of treatment with a decrease in heterogeneity and tumor stiffness has been reported. Currently, in these situations, other imaging methods should be used. I also show you a case monitoring chemotherapy treatment, which are evaluated by SHEARWAVE elastography and 3D SHEARWAVE elastography. And the four recommendations of this guide, ultrasound elastography could be used to increase diagnostic confidence in the characterization of a breast lesion. And the last one, a BRAF3 lesion appearing stiffer on breast ultrasound elastography should be considered for biopsy. For example, in the image, we could see a hypoechoic lesion, which are the biggest diameter is larger than taller. So show could be taken for a benign lesion, which are in elastography of 5 degrees on the elastogram. At the end, breast elastography is used for differentiating benign focal lesions from suspicious focal lesions, and differentiate low and high stiffness. Strain elastography and SHEARWAVE elastography are used for improving the generally high sensitivity and specificity of the BRADs, and it is recommended that they are used and adds ones to the B mode ultrasound, not at all to replace the B mode ultrasound. But we also could speak a little bit, and on the future, I hope we could speak much more and depass these limitations. For example, personal technical limits, soft cancers in situ, hard cancers about evolution, diffuse cancers, very big tumor, which are not, for example, it's not possible to measure a very big tumor and to evaluate in SHEARWAVE elastography, millimetric cancer in fatty breast, and also liquid pathology, which are not so well described. Thank you very much.
Okay, thank you very much, Professor Enachescu. We have only one question. If you think that 3D elastography has advantages over other elastography methods, and if you think that it will bring additional information.
Yes, I think we could refer at additional information which is brought about as a 3D ultrasound, the coronal plane, which are demonstrating the whole lesion and the volume of the lesion. And another point of view is the fact that is a good method for acquisition method and for and for study the lesion after the exam, and establish some correlation between the three plans. On the other side, I think the SHEARWAVE elastography is not complete known and not complete evaluate for study breast lesion yet. I think we have to make some progress more. So I think it's the same additional information as we have in 3D ultrasound. I don't see another one. Thank you.
Okay, so thank you very much. There are no more questions, so thank you one more time.